Thank you. So yeah. I'm Anju Jaiswal. I'm one of the child psychiatrists here at UNM. I work for a long time in inpatient setting, and currently I'm medical director at Children Psychiatric Center. I also work in outpatient setting with children of all ages. So today's topic is regarding ADHD through the lifespan. The reason to emphasize the part about lifespan is that it doesn't end during childhood, and it's a disease that continues. It's a disorder that continues throughout life. And when I was learning at that time, adult ADHD was somewhat a newer kind of concept, but at this point, there has been a lot of research that shows that it is well established and important to recognize adult ADHD as well and treat them appropriately. But I'm going to talk more from the developmental perspective and describe a little bit about how it affects during early childhood and how a person reaches adulthood before they are exhibiting other symptoms. Based on my experience of working with children and some of the research that is available. So start from the history of ADHD. In 1819, William James talked about a normal type of character in which impulse seems to discharge so promptly into movement that inhibition get no time to arise. And they call those daredevil or mercurial temperaments overflowing with animation and fizzling with talk. So at that era, people were starting to look that there were some people who were very different than others. So a little bit about the history of ADHD. So in 1922, a Homan described post-encephalitic disorders in children who had suffered encephalitis lethargica following the influenza pandemic in 1917. In 1947, Strauss talked about minimal brain damage dysfunction. DSM-1 in 1952 for the first time described hyperactivity of childhood. And then ICD-9 in 1965 and DSM-2 in 1968 talked about hyperkinetic syndrome of childhood, hyperkinetic reaction of childhood. Over the course of time, ADHD has been modified a little bit in terms of diagnostic criteria through the DSM. And you can see that in DSM-4, it was described as ADHD and ADS. So it was described as more, people knew that there are two different varieties of ADHD. And in DSM-3 in 2013, they loosened teen and adult criteria to incorporate some of the symptoms that were evidenced once they were going through teenage and adult years. So some statistical data about the ADHD per 2016 information. The ADHD is a mental disorder that most commonly occurs in children. About 6.1 million American children, that is 9.4% of children aged 2 to 17, have ever been diagnosed with ADHD. The average age of ADHD diagnosis is 7 years. The age when symptoms typically first appear is between 3 to 6 years. Males are 3 times more likely to be diagnosed than females. And during their lifetime, about 12.9% of men will be diagnosed with the disorder, whereas only 5.6% of women will be diagnosed. The percentage of women has gone higher compared to the previous data, which was like around 4.9%. The important part is that it's not just a childhood disorder. Today, about 4% of American adults over the age of 18 deal with ADHD on a daily basis. So when we think about the developmental perspective of what kind of symptoms we are noticing early during developmental phase, I want to emphasize a few points which will help us to understand the diagnostic criteria that DSM has set. So in infants, you will hear stories about that the child was very active in utero. After birth, there are more difficulties with sleep and feeding issues. Many people describe them as colicky and crying constantly, difficult to soothe, difficult temperament. It's commonly associated with maternal cigarette or alcohol use, low birth weight, and brain injuries during in utero. Premature children are also at high risk for developing ADHD symptoms because of some difficulty in maturity during that time. So as they go to preschool, about 40% of children with the ADHD exhibit symptoms by age 4. As we mentioned that between 3 to 6 years is the age when we start to see some of those symptoms. And as they go to preschool, daycare, some of those are more obvious. They have difficulty sitting still, being read to, they're non-compliant, throwing prolonged temper tantrum. Parents state that they need to child-proof the home, must provide more supervision compared to normal kids, have difficulties with babysitters in daycare settings. So we often hear some of these kids being kicked out of daycares on multiple occasions because of acting out disruptive behaviors and not listening and following directions. By the time they come to the school age, which is the most common age, is 7 for the diagnosis, the problem accentuates because they have to follow the normal norms of sitting in the classroom, listening, following direction, which they have significant difficulties with. So there is high rate of off-task behavior, non-compliance, temper tantrum. These kids are at risk of learning and academic problems characterized by being immature, not able to retain information, and they're 3 times more at high risk of being retained in the same class because of immaturity. They are more prone to have poor social skills because of being rejected by others. These are the times when, because of being a difficult child in the classroom, they start to be getting a lot of negative reinforcement by the teacher, by the parents, by society, and that kind of builds up in feeling socially rejected. By late childhood, 30 to 50% develop symptoms of conduct disorders such as fighting, truancy, stealing, which is kind of indirectly a side effect of ADHD. So in adolescent age, what we see is that 50 to 70% continues to have poor attention and impulse control issues, although hyperactivity start to reduce. So they are not bouncing all over the place, but definitely they continue to have impulse control issues and attention problem. Many inattentive type, about 20 to 30%, may not become impaired and meet criteria until middle school. So that is one of the area to really keep a close eye on. If the kids are not doing very well in middle school, to look for, even though they may not be hyperactive. We get a lot of referrals for kids to come and see pediatricians or primary care provider or psychiatrists because of being disruptive in the classroom. But the kids who are having just the attention problem get missed because they are able to survive and do okay if it is of mild to moderate variety, because they may not be getting a highest grade, but they're somehow able to pass and go to the next grade and doesn't become problematic child. But by the time they come to middle school, some of the school pressure is increased. There are more executive functioning tasks required, and that's where they start to have more difficulties. By the time they go to high school, many of these kids start to drop out of the school, 30% compared to 10% of normal controls. 5% of ADHD students go to college compared to 41% of normal controls. So dropout rate is very high with children who are not diagnosed or properly treated with ADHD. Increased risk of car accidents, substance abuse, juvenile delinquency, which is very sad. If in some of our rotation at the juvenile detention center, we have seen that many children who are there for some sort of legal issue often have comorbid ADHD symptoms, and many of them were either not diagnosed or not treated properly, or they just stopped taking medications and got into these kind of delinquent behavior that led them to get that sentence. 25 to 35% of ADHD children will be referred to juvenile court at least one time. So that's a population very high risk where it could be preventable if it is properly treated. So by the time they go to adulthood, as we mentioned, some of the hyperactivity type of behavior gets minimal, but the other part which is important to regulate starts to accentuate. And what we see about adult ADHD people is that they have poor time management, disorganized behavior, may avoid tasks requiring sustained attention, difficulty starting and completing tasks, they get easily bored, and these kind of complications relates them to frequently stay late to complete their work, takes longer time than peers to complete their work. So they start to get behind and not perform as high as they could otherwise. They impulsively quit the job or end relationship. So it leads to multiple social rejections and problems. Because of not being able to go to college or because of not being able to sustain good jobs, they are at lower socioeconomic situation than their unaffected siblings or friends. And all these things leads to low self-esteem, social problems due to frequent interruptions, not listening, being unreliable, etc. So these people are also at increased risk for smoking, about 78%. The arrest is 2 times higher for ADHD adults. Unemployment is 3 times higher. STDs are 4 times higher. Suspended driver license is 5 times higher because they are often making those kind of impulsive, not so good choices during driving, or they are involved with substance use that leads to these kind of problems. So going to the DSM criteria about ADHD, as we kind of touched on many of these topics while talking about the developmental course, but the important part about the DSM is that it is divided into 3 different categories. Number 1 is ADHD predominantly inattentive type, which is the population where we have to have at least 6 symptoms during childhood out of these categories, which includes fails to give close attention to details, makes careless mistakes in schoolwork or other activities, difficulty sustaining attention, does not seem to listen, does not follow through instructions or fail to finish schoolwork, have difficulty organizing tasks or activities, avoids or strongly dislikes tasks, many of these people will say they hate school, they don't like finishing, they don't like to do homework because it's really complicated for them, loses things necessarily for tasks or activities. They will finish the school assignment but just forget to submit it on time, easily distracted by external stimuli, forgetful in daily activities. So they need to have at least 6 of these symptoms present in order to be diagnosed with predominantly inattentive type. So next category is predominantly hyperactive or impulsive type. So again, they need to have 6 out of all these symptoms, which includes being fidgety, restlessness, difficulty sitting in seat, leaving seat in the classroom or other situation, running about or climbing excessively in situations where the behavior is inappropriate, difficulty playing or engaging in activities, unable to be or comfortable being still for extended period of time, excessive talking, blurting out answers, interrupting the class, interrupting any kind of social group, difficulty waiting in lines or taking their turns in games or group situations, interrupting or intruding on others, which is very easy if somebody has those symptoms. A couple of other things which are important for the DSM criteria. So if somebody has only inattentive 6 symptoms, but not enough to call them hyperactive, they're called ADHD predominantly inattentive type. And if they have 6 in hyperactive, but not in inattentive, then they're called predominantly hyperactive type. But if they have 6 or more symptoms in both categories, they're called ADHD combined type. Now, the other part is that the onset has to be before age 12 or no later than age 12. Symptoms must be present in 2 or more situations. So if it's happening only in the home setting, it's not enough to call it ADHD because there may be some other stressors at home. There may be other reasons why a child is acting out the way he or she is. So we always have to have 2 different situations taken into account. For adult, it could be work and home. The disturbance causes clinically significant distress or impairment in social, academic, or occupational functioning. Disorder does not exclusively happen during the course of schizophrenia or psychotic disorder, and is not better accounted for mood, anxiety, dissociative personality disorder, or substance intoxication or withdrawal, because those can present in similar way, and we have to make sure that that's not interfering with it. In addition, ADHD is specified. So according to DSM, we can specify it as mild, moderate, or severe symptoms depending upon the impairment present. So how is it different from children to adult in terms of the DSM-5 criteria? So the only difference is that for children, we need 6 criteria in each category. For adult, we need 5 criteria. But other than that, it's exactly the same. So in clinical, so often when the parents or the person presents to us for evaluation, there are a few scales that we use commonly. The most common scale used for the children is Vanderbilt assessment scale, where we have a parent form and a teacher form. So we always give them this form to be filled by the teacher so that we can assess how they're functioning in school setting, and one of the parent or care provider can fill the form. For adult, there is a self-report scale. I think it's a little bit tricky when an adult has not ever gotten that kind of help, because the diagnosis or some of the symptoms needs to be present before age 12. So sometimes it's important to talk to parents or siblings, older siblings, to get that kind of information in order to diagnose. And certainly clinical interview is important. So Vanderbilt scale, assessment scale not only just gives the idea about ADHD, but it also has some questions which gives idea about anxiety, depression, behavior problems, um, and learning issues. So sometimes in child psychiatry, this is very helpful because we can see if there are other areas which are affected, and we can do a follow-up assessment after treating them with the right medication to see if those areas are improving, and still there are other areas which are affected in terms of like depression, anxiety, and learning issues, so that the child can get the right kind of evaluation to address those areas of need, because not everything is just ADHD. So there is no one cause behind ADHD. There is no one gene that really is responsible for that. However, uh, there is significant genetic predisposition and heritability for ADHD. It is a brain diagnosis, it is a neurological diagnosis, and that's one of the things that needs to be emphasized in learning part, is that it's not a behavior diagnosis. People don't necessarily just act out the way they are acting out during childhood or adulthood. Their brain is wired in a different way, it's structured in a different way, and there is enough research that has happened in these fields to prove that. Some of the high risk factors, in addition to genetics, is the exposure to toxins during pregnancy. Cigarette smoking has been associated, alcohol or drug use during pregnancy, exposure to lead or other toxins at a younger age, um, a lower than normal birth weight, and certain type of brain injuries can definitely make people more susceptible to develop these symptoms. A little bit about the areas of the brain that is affected to understand ADHD. So there are 4 different areas which are most affected which leads to ADHD symptoms. So one of the most important area that you'll hear a lot, which is responsible for many executive functionings, is the prefrontal cortex, which is this orangish red color. So this area is responsible for organization, cognitive flexibility, self-control, and maintaining attention, which is significantly compromised. The next one is this bluish area, purple area, which which is a basal ganglia, helps regulate communication within the brain, responsible for motor control, facilitating movement, and inhibiting competing movements. So the physical activity part of it is regulated by basal ganglia, and many of these kids are very clumsy. They have sometimes some difficulty with the fine motor issues, and of course they are very forgetful. So some of these things relates that way. Next is the limbic system. So we know that ADHD kids or adults have a lot of other comorbid issues, and ADHD itself can lead to a lot of these temper tantrums or low frustration tolerance in certain situation, acting out behavior. Most commonly, children are referred to us from school because they are being aggressive in the classroom. So their limbic system is also somewhat affected, which is responsible for regulating emotions, and deficiency can lead to restlessness, inattention, and emotional volatility. Reticular activating system, which is a blue area here, is responsible for major relay system among the many pathways that enter and leave the brain. So it's responsible for arousal and consciousness, and deficiency can lead to inattention, impulsivity, or hyperactivity. So these 4 areas are affected in ADHD. And I do want to mention one thing that I've mentioned in my bibliography as one of the talk by Dr. Barclay, who is a renowned neuroscientist, has done a lot of research in ADHD, and he describes and explains it very beautifully, that one of the most important part of ADHD is difficulty with inhibition. So we see that these kids are suddenly being hyperactive, and any environmental stimuli, they absorb everything. So many times people think that maybe they are hypersensitive to perceiving these environmental stimuli, but they perceive these environmental stimuli similar to any other normal person. The problem is in the area of inhibition. So the inhibition that happens, that causes problem in these children or adults is that they cannot stop. When a stimuli come, they have difficulty stopping, thinking, and responding to it. That area is significantly affected. The number two part that is difficult for them is the ability to shift their attention to something else. So you will hear for many of these children that they are able to pay great attention to playing video games or watching TV. And whenever somebody says that, it's time to stop doing that and move to something else, they have a major temper meltdown or temper tantrum. So they have this difficulty in interrupting that particular task or stimuli. So their brain is somewhat perseverative about those kind of impulses, and shifting from one activity to another activity is hard for them. The third area of inhibition that we see in them is about ability to protect the frontal lobe functioning, which is responsible for all these executive functioning. So if they are doing certain things, and if they have to stop doing that, that part is very difficult for them. And they get so for example, like I'm doing a presentation right now, and if there is something going on in the background, or somebody else is blowing cleaning carpet, and that sound is coming. So these people have difficulty ignoring those sounds or those stimuli that are going on in order to be able to really continue the focus on the activity that is goal directed for them. So they get distracted very easily because of that reason. And once they're distracted, it's difficult for them to come back, and that affects their ability to really grasp the new concept and keep it in their working memory, to learn new things. And that's one of the reasons that sometimes their performance is not good in school setting or a job setting, because they don't they get distracted very easily, and it's very hard for them to come back to that particular focus. So that being said, I want to spend a few minutes to talk about a lot of comorbid conditions that happens with ADHD, because especially in psychiatry, we do see presentation with the comorbid symptoms more commonly than just with pure ADHD. For children, as you can see, the learning disability is 45% compared to 5% without ADHD. Conduct disorder is 27% compared to 2%. Anxiety is 18% compared to 2%. Depression is 15% compared to 1%. Speech problem is 12% compared to 3%. So some of these things happen as from the developmental perspective, like speech problem, learning disability, and some of the other things develops over the course of time, but could be comorbid with or without ADHD. But definitely ADHD makes them a little bit more prone to develop depression, low self-esteem, anxiety, and those conductive problems. And some of the data about the coexisting conditions for adults is also pretty remarkable. I won't go over all those, but you can see that mood disorder is significantly high, 38% compared to 11%, depression 18% compared to 7%, bipolar 19% compared to 3%. They developed a lot of phobias. Social phobia is 29% compared to 7.8%. Substance abuse problem is significant with this population. Any substance abuse disorder is 15.2% compared to 5.6%. Alcohol dependence is 5.8 compared to 2%. Intermittent explosive disorder is 19.6% compared to 6%. So definitely they're at high risk for all those problems. Now, 62% of children between 2 to 17 years that suffered from ADHD had been taking medication or are treated with that. 47% received behavior treatment for that, and 60% had of 2 to 5 years of age received some type of behavior treatment. So in early childhood, behavior treatment is very important. We don't jump into prescribing medication from the get-go, or at least try to avoid it. I do work in 0 to 5 clinics, as many patients we see who presents to us between age 3 to 5 years have significant issues related with attention and hyperactivity. So the important part about this is that the treatment that works best is a combination of medication and behavior therapy. And 64% people have other mental disorders in addition to ADHD. So the treatment is not just medication, especially for children. When they're diagnosed with ADHD, we do incorporate multiple modalities of treatment. So parent training, understanding that this is a brain disorder, they're not doing it purposely just because they want to make everybody else's life difficult around them. They are having difficulty maintaining those behaviors. Classroom interventions are very important because many of our children are definitely referred by the school teachers. So psychoeducation to all parties involved, including the child, so that they don't feel guilty and develop low self-esteem about their behavior issues. Medication therapy, pharmacological therapy has significant role, and I'll go over a few of those medications that are very helpful. For many parents are hesitant to try stimulant for some of these children, and there is a lot of concerns about prescribing stimulant to older adolescents and younger adults because of concerns about substance use issues. But the important part is that if it is prescribed under control or supervision of a prescriber, actually it prevents substance abuse problems, and it prevents a lot of other comorbid developmental issues than causing addiction on stimulant medication. Certainly CBT therapy with more behavior intervention placed, social skill training, dietary interventions are not that significant, but there is some role. Family therapy to really help these kids because they need a lot of external support while growing up. So some of the things that family can do to structure their surrounding could be very helpful. So as we know that many of these ADHD patients present with comorbid symptoms, so it's important to do very proper diagnosis of and keep comorbid conditions in mind. And if the comorbid condition is more severe than ADHD, then we first treat that and then go to treat ADHD. If there is a personal preference to not try stimulant, then we go to non-stimulant medications like alpha adrenergic medication. Some of those are clonidine and guanfacine, or there is another medication, atomoxetine, commonly known as Strattera. Those are the non-stimulant medication. Otherwise, for ADHD, especially for inattention type, stimulant is the drug of choice. And that is the gold standard of treatment. So the stimulant, there are all different varieties of stimulant in market. Over several years of medication history, stimulants has been there for longest period of time, and there has not been any new stimulant that came in market. But there are different varieties of stimulant that has come and evolved over the course of time based on the duration of action, like short acting, intermediate acting, long lasting stimulant, because that can really be helpful when you're managing these children or adults. So depending on the response, their stimulant and non-stimulant medication could be combined as well. So some of those common names that you will encounter are methylphenidate, dextroamphetamine. So there are different varieties of Ritalin. Focalin is extended release. Concerta is the longest acting Spensuel, which releases a little bit of medication immediately, and other part gets slowly released throughout 8 to 12 hours time frame. Similar to that, there are other variety of Adderall, Vyvanse, which are available in market that could be prescribed depending on the need of the patient. So the non-stimulant medications, as I mentioned, is Strattera, guanfacine, clonidine, and guanfacine and clonidine comes in extended release form and are very helpful in that way because it could be prescribed once a day. Otherwise, a child has to go to a nurse's office in the middle of the day and get the medication, which sometimes they do not like. Strattera acts more as antidepressant medication, so it is slowly built up in the system and takes 4 to 6 weeks to have complete benefit and is dose dependent in terms of how we prescribe it. There are other medications like Wellbutrin or bupropion is most commonly prescribed for ADHD symptoms. And sometimes we choose that if there is comorbid depressive symptoms along with ADHD symptoms, or they do not want to try any stimulant medication. Alternative medications are not that robust in terms of evidence-based research. However, there are some research that definitely shows that omega-3 fatty acid can be helpful. And there are some research where they combined multiple supplements and vitamins and L-carnitine, and some of those studies have shown this decent benefit out of it. However, those might be more beneficial for mild cases, and we don't see a whole lot of benefit just with those interventions with moderate to severe cases. However, it can have some place. Some of the diet interventions are that definitely, probably too sugary diet can make people hyperactive. Good healthy lifestyle and proper diet rich with different nutrients is always advisable. Sometimes with younger kids, when we are not able to prescribe medications, we have even recommended family to try some coffee beans, which seems to be helpful. Some parents do describe some of the Mountain Dew being helpful. So caffeine definitely has some roles in helping them with the attention part. However, it could be hit and miss and could be more appropriate for mild cases. So just to emphasize the importance of treating not only kids, but also adult ADHD is that it improves the performance, self-esteem, comorbid anxiety and depression, Many times in some of the studies, it is seen that if somebody has significant anxiety along with ADHD, if you treat ADHD, the depression and anxiety itself improves. Stimulant is one of the adjunct medication treatment for resistant depressive disorder as well, for the similar reason that it works in some of the parts of the brain where it is helpful to improve those symptoms. Definitely it reduces risk-taking behavior, including substance abuse, relationship. There are some studies which shows that it improves generally life expectancy, and in some of the Sweden and Europe studies, it has shown that up to 10 years of life expectancy is a difference between adults who have ADHD and who do not. And it could be compounded with a lot of other factors that plays a big role in terms of how they are able to achieve things in life and all the other risk factors that comes with ADHD if it remains untreated. I mean, in dual diagnosis, we often run with the problem of addiction and ADHD, and there is a lot of concern sometimes to prescribe stimulant medication with the concept of that it can cause addiction. However, research clearly shows that people who are treated with the appropriate monitoring, they have less chance of really being addicted to any other substances, and they do not get addicted to stimulant medications. The important part is that one should not prescribe several months of supply at one time, and they should follow up with the appropriate provider for monitoring and improvement. But yeah, all the other treatment modalities are very similar that we do for dual diagnosis patients otherwise. So that's the bibliography. So I'll stop sharing. I know we have just a little bit more time, so I'm happy to answer any question or talk about anything else that people may need to know. And let me. So if anybody has any question, please feel free to ask. So it seems like it's a wide group.
Dr. Jaiswal, we just got something in the chat. And it asks, what are your thoughts on medicine for ADHD?
Yeah, so definitely, you know, being a child psychiatrist, we often prescribe medication. My thoughts on ADHD medication is that, as I mentioned, that it is a brain disorder. So there are certain parts of the brain which are not developed appropriately or have a neuronal network which has developed differently than normal people. So if somebody has diabetes or high blood pressure, it's not their fault, and there is something with their body that where they don't have enough of their body part is not functioning appropriately. So it's similar for ADHD. So I feel like with that concept, it's very important to keep that in account and prescribe medication. That being said, not everybody need to be prescribed medication. There is always a very important role of behavior therapy and other psychosocial interventions that are important whether you prescribe medication or not. So we always recommend to combine medication with other modalities of treatment, including organizing their surrounding. The adolescents or the adults, they have a lot of difficulty with executive functioning. So organizing those things like having a planner, putting sticky notes about their assignment deadline, making a routine if they have 5 different things to do in a day, um, teaching some of those skills to parents to really help their kids when they're younger, um, to allow them some time to organize those things, and is very important. But in general, I think that medication has a significant role for definitely for moderate to severe cases of ADHD.
Okay, we'll just give it another minute or so here if anybody has any questions for Dr. Jaiswal.
Yeah, and I just want to mention, we have, I know some of the people are familiar at UNM about how to reach out to our clinic for any complex cases of ADHD or combined cases of ADHD with other comorbid conditions. We are also available on PALS line to provide any kind of consultation for people. We sometimes do get some of the calls from all over New Mexico from primary care clinic to ask questions about certain things and how to prescribe medication or whether it's appropriate to do any particular medication if somebody has questions. So in the chat, there are a couple of other questions. What about treatment for adults? So I would say the same thing. The treatment for adults is mainly stimulant, and there are some non-stimulant medications like atomoxetine or Wellbutrin, called bupropion, and there are a few other antidepressant medications also have some role in helping with ADHD symptoms. So definitely if any adult is having significant problem, they should reach out and get evaluated because medication can help them to reduce some of the other risk factors that comes because of that and can improve there are a lot of research that shows how it changed somebody's life once they were treated as an adult with some of these medications. Long-term effect, definitely there are side effects of these medications that we go over. Close monitoring is important. Most common side effects are some changes in heart rate, blood pressure. There is a lot of controversy about growth reduction, but we don't see that as often as otherwise. Appetite suppression is one of the most common side effects we see with stimulant medication. So we work around that. If they have side effect on one medication, doesn't mean that they will have on other stimulant too. Sometimes they cannot tolerate long-acting medication because of suppressed appetite. So for those patients, we do prescribe shorter acting so that they can eat in between, because the suppression of appetite is very much related with the medication and dose. Sometimes dose reduction can help with that. Many times we recommend the kids to have a drug holiday. So over the weekend, they can skip taking it if they are not required to do certain things according to the school. Over the holidays, like Christmas holiday or summer holidays, they can take breaks so that their body gets chance to eat properly and develop properly. If it is a significant side effect and is not modified with any of the maneuver, then we try non-stimulant medication for those patients. So we always monitor for side effect. We don't see as much side effect as people worry about and managing it with multiple different variety can be very helpful. So one of the question is about stigma related with people growing up in stressful, low socioeconomic communities with accepting the diagnosis and getting the right kind of treatment. So definitely, psychoeducation, that's where I feel like people other than psychiatrists have a significant role. When these children or adolescents or even adults are coming to their primary care provider, that may be an opportunity to provide the psychoeducation. The emphasis about that this is a brain disorder and it is nobody's fault is very helpful. We do provide some of the education to the case managers and other people who are working directly with the community people to go to their home and provide other psychosocial support to understand that, if you have any of these type of clinical symptoms, then it's okay to have an evaluation and see if there could be something to help with it. I think there is a lot of emphasis about from school and other places that comes if a child is acting out, then they're bad kids, and I think that stigma definitely avoids some of the people to get the right kind of help. So providing as much as psychoeducation and other kind of talks in a setting where it's not directly relates with putting them down is very helpful for any of these cases. Now, we do see a lot of comorbidity with the stress and trauma developing, and we get a lot of patients with comorbid trauma symptoms and ADHD. So for those patients, definitely ADHD treatment is important, and we can address those easily with some psychotherapy and appropriate medication choices. So identifying those cases is very important. Last question, what about use of caffeine? So definitely caffeine has beneficial effect. Now, if somebody uses caffeine too much, then they can accentuate some of the restlessness and hyperactivity, anxiety type of symptoms. So too much caffeine is not helpful, but small amount of caffeine is helpful for patients. And in fact, like I was saying that in 0 to 5 clinic, when we want to avoid prescribing medication, we have sometimes even recommended families to try coffee beans. It needs to be pure coffee beans, and they can just take small amount of that, and it could be helpful without causing significant side effect. The withdrawal symptoms from caffeine is something very important. So that's what I remind adolescents or adults to not get hooked up with always drinking caffeine, because withdrawal can cause a similar kind of symptoms.
Okay, well, thank you, Dr. Jaiswal. I appreciate the time you took to speak with us today.
Sure, you're welcome. And like I said, that anybody has any question, they can always reach out to us in Child Psychiatry for any consultation. We'll be happy to help out in any way we can. And thank you for taking.
Awesome.
Most of our ADHD patients are being taken care of by